Hey everyone, we are here at the Recovery.com Marketing Summit in Madison, Wisconsin. I'm sitting here with
Steve Donai, founder and CEO of Sherpa Consulting. I'm based out of Charlotte, North Carolina.
First and foremost, thank you for managing the tech expert panel we spoke about earlier. Really good conversation, and I think I'm going to return the favor now by giving you some curveballs questions back, if that's okay with you.
Absolutely. That was a great time, the three of us talking about technology. It could have been longer, 45 minutes.
Yeah.
I thought it went great. It was good.
Absolutely. So we didn't get to ask you so many questions. So let me start by asking, what is your company focusing on now in terms of revenue streams, and how are you helping behavioral health facilities?
Yeah, so Sherpa, as you know, is cross-departmental in nature. So all the projects we take on are going to be something to do with either admissions and marketing, BD, and some sort of multi-departmental task. What we're really looking for now is ways of solving challenges and problems I don't think treatment centers really know they have. So for instance, we talked about this a little earlier, very briefly. One of the challenges I think in addiction treatment, mental health treatment, eating disorder treatment that other healthcare providers don't see typically as much is the singular revenue stream, right? You have billable hours, billable days, and that's it. Similarly, you have a lot of seasonality that we know something that comes up. So what do we see every single year for these treatment providers? December comes, they freak out. January comes, people are full again, and we haven't figured out, okay, there's going to be seasonality. There's a single source of revenue. How do we overcome that? So we've partnered with another company to work with treatment centers to install in-house pharmacies. So the treatment center actually owns the pharmacy. And so it's cool from the side of, okay, it's going to generate revenue considerable for the treatment center. But then what it also does is solves the other problem that treatment centers have, which is post-discharge. How many patients say, I don't have access to a pharmacy. I have a hard time getting my meds. I can't see my doctor getting meds. Well, they can actually stay engaged with that pharmacy. And I think this is really unique because now a patient can stay engaged with their treatment center months, weeks, years, for a long time. And the treatment center still has a clinical medical reason to connect with them. But you're able to engage your clients longer. It's a wonderful way of diversifying the business, providing stability in the instability season. So that's one of the things we're trying to do now is we're really trying to work with programs to solve for issues that they might not know they have with solutions I can do.
I love it. Absolutely. That's blue ocean strategy to the T. What is an ideal client profile for this kind of initiative program?
Yeah, for a pharmacy alum, everyone call it. Yeah, so I think it's typically a treatment center that has a moderate level of success. I wouldn't do this for a new program right off the bat. It's a program that has their infrastructure in place in a good bit. So our first client we've introduced it to, we've helped them with everything from a telephony system to training of staff to CRM. So they're now ready to be able to do something like this. But I would say at basics, they have to have a level of success, a level of core values, internal systems and structures, a telephony system that's good because obviously now people are calling for the pharmacy.
Yeah.
An HR department that knows like you now have other HR things to work with. So that's generally the folks that I would say you should be the first in line to do something like this.
Okay. So when you're speaking about the telephony system, sometimes what I've seen with facilities is when there's, I won't say conflicting interest, but there's a different kind of levels of care, calls or programs. They come in, somebody may have a DUI course program, and then they also have residential treatment offering, and the revenue is different from those different programs. How do you make sure that the pharmacy is not impacting, or who's answering all these calls, making sure they don't hit those 30-40% missed call rates?
Completely different line of answering. Yeah. So I think with this, because it's truly a different business, different LLC or however you structure it, the phone is being diverted over. So you don't want admissions people, and it will happen to some degree. So you have to cross train them, but you don't want admissions people filling prescriptions for metformin. It's going to happen. I mean, we work with clients all the time. I'm sure you do too, where they get calls for job openings, and it's like, okay, just stick to the buttons on the thing. But we want to set it up, obviously, where unique phone number, unique way to get directly to the pharmacy, have the IVR set up so if they accidentally still do hit the main number, they can go directly to the pharmacy and route it that way. So I think that's the big key. And I think as long as you're doing that, you are staying out of a whole, we're trying to divert. Of course, then I think the question comes, does the program allow outside non-patients to access the pharmacy?
Yeah.
I think there's some good business use cases for it. One of the programs I work with has a pharmacy desert. There's no pharmacy within 2 miles of their facility, but tons of humans. So there is a use case and a thought process of, do we open this up to the public? But if you do keep it as a closed door pharmacy and just in-house, then I think you can manage it pretty easily.
Yeah. That makes sense. And is there any expectations or projections as for increase in readmission rates, referral, alumni, professional, as a result of like having that staying top of mind with alumni and patient discharges as you leveraging this initiative?
Yeah, I think there's a couple of things that we can nerd out on this. There's clearly the alumni stay. So let's say you, a 1/4, 1/5 of discharged patients stick with your pharmacy.
Yeah.
But they don't want to go to Walgreens and say, here, I need Suboxone. They don't want that public knowledge. So they can stick with the pharmacy and get the drop shipped to their house. And so there's interaction, right? You can have a HIPAA compliant way now also of knowing if that patient relapses and needs to go to the hospital, because now all of a sudden the new meds hit the chart because of the system. So then I know, oh, that's not the meds I prescribe you. That's what the meds prescribe for a, OD. Let's call you up and do that. So I think that engagement level is going to be very big. I think what makes it fun too for guys like you and me is we now have a better access to outcomes data, and we can now see how people are doing post-discharge in a much easier way, which then helps us tailor our front-end marketing to who we're treating best.
Yeah.
And so I think it gives us this really unique way of saying, hey, like, we can really dial in who we do the best job with best outcomes and start there and have this whole cyclical approach.
Absolutely. Yeah, now that you mention it, Bernie from Recovery.com, we met in, you were there too at San Diego Rollover Rep Padres event, and he put me on the spot. He was like, we have this CR enhancement, this little wheel tech stack with all the different technologies and how integrating the VOB software, the EMR, and call tracking and all the different aspects. And it was like, I'm not seeing any patient outcome software in this wheel. How do you think patient outcomes are going to, is that going to be an influential factor for the industry moving forward as for the leading facilities? Or I know there's different viewpoints on that.
It's been a weird industry. So I came from surgical sales prior to doing this. And, you get hired there, you get all the white papers, you get all the outcomes, you get all the research. And statistically, they have to reach certain thresholds to go to market.
Yeah.
Here, you don't need to meet outcome thresholds at all. You just need to have certain clinicians and things in place to start a program. So I think just from behavioral health in general, catching up to the general medical population, we really need to do outcome studies. I can't think of another vertical in healthcare where most of the providers don't know how they get their patients and they don't know how the outcome of their product is. It's so wild to me.
Yeah.
So I think that from an outcomes position, just from the baseline of saying, are we actually doing what we say we're doing? Everyone should be doing it to some degree.
Yeah.
You've got 7 PHQ not. Some of these tests they should probably be doing upon admission, upon discharge, 60, 90, whatever, and find those intervals.
Do you think there's going to be an adjustment from the insurance companies in terms of payouts to that degree of it being measured?
It should be. I've heard both. I sincerely believe it should be. If I was an insurance company, I have heard people who negotiate more with insurance companies than I have in my career say they truly don't care, which is wild. Might make sense, I guess, as a line item. Behavioral health is so much smaller than like cardiac arrest.
Yeah.
But I think just from a program standpoint, to diversify yourself, to know if what you're doing is working, to actually provide value, you need to find a way to do it. I also sincerely think a lot of people don't do it just because the reimbursements are already very low compared to the revenue acquisition. They find it very difficult to allocate anything to that, which I get. So I think it's just some growing pains we might be going through.
Yeah. I really also like this initiative about the internal pharmacy. It makes sense in so many different aspects. What are other ways that you would say you can increase the patient lifetime value for a facility that's just obsessed about that initial cost per acquisition and, hey, we're expecting them 30 days at rest treatment?
Yeah, so even if you withdraw, like I think other revenue channels, advocating for days is probably one of the biggest. Strong AMA blocking protocols. I've worked for a couple organizations whose AMA blocking protocol is outstanding, and they really empathized. They really got with the person and made it very difficult to leave. Average length of stay, as that compounds, makes it a lot easier. I mean, if you have a 30-bed facility and you can increase your length of stay from 28 to 30 days, well, that's like an admission or two you don't have to get. Yeah, it's a big deal.
Yeah.
Billing for AMA blocking is available as well. A lot of people don't bill for their AMA blocking. There's actually a crisis intervention code that you can bill for. So you're not just doing it for one, you can do it and also get reimbursed for it. So I think those are the big keys to look for it. And I think also on that note is if you're running a treatment center, knowing who your core demographic is, marketing to your core demographic and not varying from that will increase average length of stay. I mean, how many times have you worked with a program that says, we'll take anyone who wants to get sober? And then milieu gets sideways, 10 people AMA, Monday morning hits, they're freaking out, and they took, and it's because there's no cohesion in the patient population.
So they're so desperate to acquire patients that people show up, and then the reality is something different than the actual landing page and the admissions rep making the promises, and they can't resonate or relate to anything. So that makes sense. What are though you mentioned some of those AMA blockers, the top strategies? What are a few? If you could mention one, two of those?
Definitely not my world. I could say the sense of urgency was probably what I've noticed most. So some of the things I've done over the years, I've gone undercover in treatment centers a few times under an alias. And I show up as a patient, and I admit,
Mr. Sherpa. Okay, I like that.
So my name is Matt McGlon when I go to treatments. He's actually a buddy I used to work with, and asked me if he could, I'd use his name. So Matt McGlon has been to treatment several times on an alias, but each time I will fake AMA. And I'll see how the staff there reacts to me AMAing. And the one time I think they did it tremendously. The best way I can describe it is like I kicked a hornet's nest. They were all in action so quickly. I was immediately in the director of nursing's office. It was very quick and precise and compassionate. There's nothing like lackadaisical about it. It was a sense of urgency, and so I think that I can't speak to the clinical prowess of it, but I can say just it was noticeable the second I hit that hallway with my roller bag in hand and a change of clothes. They were on it.
Oh wow!
Yeah,
that's model. What about, have you done mystery shopping on the front end with clients in terms of how are they following up on the lead? How's the admission that interacting? How do they call? Or you basically analyze the existing?
Yeah, we listen to, but I'll tell you on that, I do homework with a lot of my clients who do admissions or BD team coaching. Is I'll have them call their treatment centers under an alias, and I'll have them tell me what they like.
That's good. That's good.
What'd you like about the call? What'd you not like about? What'd you feel good? What do you want to learn from? I think we can learn a lot from each other, and so secret shopping is great to do. I know some consultants out there that do a ton of secret shopping on behalf of their treatment centers. They have teams of people internally that will secret shop on their treatment center's request. I dig that. It makes us better.
Absolutely. Yeah. Okay. Fantastic. So final question. Let me ask you, if you had a magic wand and or something that would really change the trajectory of this industry for the better, what would that be?
There's a lot of different ways to go with that. We touched on a few of them. I think outcomes obviously is a big one. If we all have visibility of the true outcomes, statistically significant outcomes is one. Honestly, probably the biggest magic wand that would not only change the industry, but also would save a lot of lives is you literally just picking up the phone when it rings. Yeah. It's as simple as it gets. I think that
it's incredible. Sometimes you can't see the forest for bare trees, eh? It's just like the symbol.
It's so many reasons, right? So like I always call, there's no wrong call policy. You call my facility, we're going to answer immediately. And no matter if you're fit for us or another, we're going to make sure that you go to a place that is a fit, right? Yeah. But from the human side, that person might not ever make that call again. There's shame, there's guilt, there's fear. They decide at that moment to pick up the phone. And if it's not answered, they might say, you know what? God's telling me I'll go back to drink and use him. We're doing a huge disservice. So I think that if I could just make one waving a magic wand, it would literally just be a compassionate, warm person on the other end of that phone call every single time.
Amen. Amen. That would make a world of difference for many lines across the board.
Absolutely.
You answered all my curveballs. I don't know how much. So.
Well, I appreciate it. And I hope you have safe travels back a little smoother than this one coming up here. Thank you for the trip up here. Thanks for being a part of the panel today. I appreciate it.
That was awesome. Appreciate you.
Next in the Elevate podcast.
Most treatment centers think they need more leads to fix the census problem. But the truth is, they need a better admission system. In this upcoming episode of the Elevate podcast, I sat down with Amber Vaughn, one of the sharpest minds I've met when it comes to converting calls into care. We are talking about many topics. Amongst that, we break down how to optimize your admission funnel, how to train high-performing reps, and build systems that drives results without burning out your team or blowing up your budget. So if you run marketing, if you run admissions, or the entire operation of the facility, this is an episode that will change the entire way you look at patient acquisition. Tune in for more.